Huh? And good morning. It is now September 19, 2023. I'm Dr. Deuk. We're broadcasting live. Procedure we're doing on a patient from local Melbourne, Florida. And she has back pain. She has 3 herniated discs, degenerated discs. One of them is particularly degenerated, L3-4. And L4-5, L5-S1 are more herniated with annular tear. She's got back pain. It goes down into the right side. So we're going to be repairing those 3 discs today. All right, she is snoozing comfortably. Shot. The first thing I have to do is find our access point, which is basically where do we go in to do the surgery. And the access point is going to be determined by partially the iliac crest, which is a bone that rises up from the pelvis, and you can see it's kind of blocking me right now. As a matter of fact, I'm going to have to start a little bit higher in her. Let's give her some more num-num. So her iliac crest is higher than most people. She needs us to start a little bit higher. Here you go. Shot. Shot. All right, now we're making some progress. Our target is the L3-S1 disc. That is the hardest to get to transforaminally. Jordan, I don't know about that. So I think you need to work on that. To target a place in the spine using an X-ray machine, you got to make sure it may be the best view. I don't know. I think you're off on orbit there a little bit. But the end plate's lined up a little better there, I think, right?
Looks like a little bit better.
Yeah. So what we're talking about is you have to have reliable trajectory. That looks better, I think. You have to have reliable trajectory information. I don't know. I mean, the pedicle looks good. The end plate of the vertebral body at 5 and 1 looks better, but not perfect. That's better. Actually, I think that's a lot better. Now, you could still be off on orbit a little bit, but let's give this a try. Folks, what I'm saying is to navigate successfully to a target in the spine using X-ray, you must make sure the X-ray information you're using is reliable. And what do I mean by that? Well, you have to have the X-ray machine lined up properly with the patient's anatomy, their body. Shot. All right? If you don't, you're in trouble. You'll be going somewhere. You think you're in one place, you could be in another place. So it's very important if you're doing spine surgery to get your X-ray machine lined up perfectly. That looks good. You can see she has some scoliosis. Jordan, show us at 3-4 the scoliosis. She has a degenerated disc at 3-4, definitely contributing to her pain. And we're going to be treating the 3-4 disc today as well. Shot. All right, we're almost there. Now, you can see the drapes look different today. Shot. And the reason they look different is because we're not using iodine for her. Hold on. We're not using iodine because she has an iodine contrast allergy. So when we do our discogram, you won't see a nice discogram that we normally see.
Okay, sweetheart, you're doing fine.
Shot?
Just a little.
Yeah.
Just a little pressure.
Lay still, you're doing great. I'm actually hitting the end plate just at the bottom of the disc. And the reason is my needle is being forced down towards her feet by her facet joint, which is full of arthritis there. You're fine. Shot. I'm trying to reposition the needle. You're okay. Shot. You're doing great. All right, you just have to leave it there for now. You're doing great. Everything's okay. So the patient is awake. I want them awake for this part of the surgery. They need to help me. And what I mean by help is I'm navigating the needle around their nerves, the nerve roots, and I need to make sure I'm not too close. Num num. And Jordan, Why, we've talked about this before. Why is there so much in front of the spine we're seeing that we don't need to see, and not enough in the back? Shot. And you really don't have 3, 4, I apologize, 4, 5 lined up properly. All right. Any questions from the audience?
No questions?
Let's go ahead and start our video showing shot. How does a herniated disc cause back pain?
Copy that.
Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Spending our time here, taking lots of pictures, trying to get the X-ray lined up properly with the spine. I don't see any more movement from Jordan. I think he thinks this is okay.
Now it's too much.
Should we take a poll from the audience or just?
No.
All right. That's better on the orbit. What do you think about those pedicles of L4?
No. Up,
Huh?
down, down, down,
Are
down,
they
down,
lined
down,
up?
Down, down. What are you doing? There. No. Okay.
All right. They're still they're worse there. So I think you have a wag issue, right? That's better. I think that's as good as you're going to get it right there. That's as good as we can because there is some scoliosis. Okay? Took a while to get there, Jordan, but we got there. How's she doing? All right. Shot? Shot? That looks good. She has interesting facet anatomy. It keeps forcing me south on her level. Shot? So I'm going to draw back. Shot? And I'm going to try to go a little bit further north. Shot? Nice. That's better. Shot? All right, so again, we're right there. And when you're touching bone with the tip of your needle, it could be a few things. One, it could be bone spur coming off of a joint. It could also be bone spur in the back of the disc. It could also be bone, like vertebral body bone. If it's vertebral body bone, you don't want to just push through it. You want to redirect, because vertebral body bone in a person who's osteoporotic, if you push into the vertebral body, you're going to end up in the vertebral body, not the disc. You don't want to be in the vertebral body, you want to be in the disc. So you never want to make the mistake of pushing into the vertebral body or bone. You want to be in the disc. All right, I would move further north. And let's try to line up that 3-4 a little better. Sometimes I can wiggle these needles, and this is the jockeying we talk about when we talk about pain management doctors being needle jockeys. They actually play with the needles like I am right now, and what we're doing is we're trying to wiggle the needle into position. And sometimes you got to wiggle things to get it in just right, because you're talking about a millimeter space that you're working through. That looks pretty good, Jordan. I think that's probably as good as we're going to get it. So we're going to try to get this next disc accessed. This is the 3-4. It's the most scoliotic and degenerated. That's just numbing medicine going in. You're doing great. Everything's okay. Sometimes patients just need to hear everything's okay. Because they worry and they think, oh, is something wrong? Nothing's wrong. We're just, you're awake. Shot. Unfortunately, we need people awake sometimes during surgery to help us, doctors. You've all heard about awake brain surgery. We do some awake spine surgery. And the reason for that is that okay? You feel it in your back?
Where are you feeling that, sweetheart? Where are you feeling that?
Shot?
In your back or your legs? Back, she said.
That's what I thought, yeah. Her back.
She was pretty convincing of that.
We're almost ready to put her to sleep, by the way. I just need another minute, and we'll be ready to go nighty-night. Shot? We're going to do the discogram. Yeah. I need her awake for that. But we're not adding dye.
Right.
There we go. See what I mean by jockeying, folks? I just jockeyed that in there, all right? So, you've seen awake brain surgery, I hope. If you haven't, Google it, YouTube it, awake brain surgery. You'll see the patient's literally awake during the brain surgery. Why do we do awake brain surgery? Because we can't afford anesthesia? No. The reason we do awake brain surgery is we need the patient's brain working and functioning during the surgery. Specifically for brain surgery, it's so we can avoid damaging what we call eloquent parts of the brain. Eloquent means needed, useful parts of the brain. And yes, you may say, well, I thought we need all of our brain, but the reality is there's silent parts of the brain that don't do very much, and there are eloquent parts of the brain that do a lot. And so when you're operating around eloquent parts of the brain, taking, say, a tumor out, or epilepsy surgery, functional surgery, you want to make sure you don't damage the parts of the brain, surface or inner parts of the brain, the tracts we call them. So you have the patient awake and doing things, playing a saxophone, talking, doing speech testing, language testing. Well, we do the same thing here in spine. We need the patient awake because we're doing navigation and testing during the surgery to make sure we don't damage any eloquent parts of the spine. Are you comfy?
Having a great time.
Having a great time.
You having any pain?
Any pain?
All right. You hear that? Ah, so that's a functional test. How bad was that on a scale of 1 to 10? How high did it go? What's the highest it went?
Give us a number. 5.
No, the highest it went.
The highest. Was it a 9?
I heard 9. All right, that was the top one. So that's L3-4, 9 out of 10. Is that where you get your back pain?
Yep.
Concordant. So basically, I needed her awake, just like we need patients awake in awake brain surgery. We needed people awake for awake spine neurosurgery, so we can get functional information. Alrighty then. Is it better?
Yes.
All right. How high does the pain go? What's the highest?
Give us a number, sweetheart.
1 to 10.
8.
8.
Man, you're a strong woman. So you could hear her go, ah, and she was arching off the bed. Clearly, that's a painful disc.
Yeah,
You're all right. We're almost done. We're going to put you to sleep in 30 seconds. So we got a 9 out of 10 at 3-4. We got an 8 out of 10 at 4-5. I don't know if we're in at 5-1. We're going to have to see. How bad is that on a scale of 1 to 10? 10? Well, we finally found a 10. All right, you get to go to sleep. Is that where you typically get your back pain? All right. So great news for her, if you're watching. We found the cause of her back pain. She has 3 discs that are damaged. We could see it on the MRI. The reason I knew they were the cause of her back pain was because when I asked her, where's your back pain, she pointed to those 3 discs. So I had an idea based on her exam. I looked at the MRI, it confirmed the finding, and we just functionally tested it and made sure, yes, indeed, you have back pain coming from those 3 discs. At this point, we're going to go in and fix all 3. I want to do 5-1 last. We're going to start with 3-4. 5-1 is always the hardest. Any questions from the audience?
No current questions.
Pretty standard schmander. Did you do the testimonial?
The patient had another appointment that they were going to barely make, and so we're going to schedule that for another time.
No worries. Shot? All right. Thanks. Shot? All right. There's the guide wire. I've taken the needle out. Next, we're going to place the dilator. You have some num-num? Num-num is our nomenclature for numbing medicine. By the way, you could see the surgery we're doing on the spine is done minimally invasive with a 7-millimeter incision. There's basically no bleeding. And if you think that's bleeding, then you should see what happens with open back surgery. There's massive bleeding. Okay, we're going to lose maybe 5 cc's. Normally we lose 2. But let's just say worst case scenario, we lose 5. Okay? With open back surgery, we would lose 500. If we're losing 5 here, we'll lose 100 times the amount of blood. Losing blood is never good. So saving blood and not bleeding during surgery is always better for the patient. Always. There are no surgeries where losing blood is better. Are there? Unless I'm missing something here. All right, so. Yeah, so basically what I'm saying is this surgery you're watching, Deuk laser disc repair, is already better than any other spine surgery for disc problems because of the blood loss is so minimal. The second thing is these patients are going home today. This is outpatient. There's no hospitalization needed. And by the way, I'm just lightly tapping here in case you're wondering. Yeah, you see the bones are separating there? Do you see that, Jordan? So this is entering the disc. You can see the vertebral bodies start to splay open. That's exactly what we want to see. So, man, my aim sucks today. So my aim really sucks today. Well, that's why I'm sacrificing my hand rather than Luis's. Luis won't put his hand anywhere near. The point is that yes, we're losing almost no blood, and more importantly, this patient will need no narcotic painkillers after surgery. The Deuk laser disc repair surgery doesn't need narcotics or opioid painkillers, which is what our entire country got addicted to. Remember the opioid crisis? Okay, that's because doctors were prescribing so many narcotics to people for back pain and neck pain that was never getting fixed. Instead, the patient would keep coming back every month and getting more narcotics and get addicted to them, like a heroin addict. They say that 80% of the heroin addicts on the street today are because of doctors prescribing painkillers. Well, with this surgery, you don't need painkillers, narcotic painkillers. These patients will take a Tylenol, maybe a Robaxin.
You know the number 1 cause of death in the United States, ages 18 to 45?
Yeah, fentanyl.
Narcotic overdose.
Yeah. So Dr. Berndes just mentioned the number 1 cause of death in the United States today, ages 18 to 45, which is young people, my son's age, his son's age. is narcotic overdose. Okay? And a lot of those patients that are addicted to narcotics are addicted because of our doctors and our healthcare system doesn't fix their pain. Instead, it just tries to cover it up with painkillers. The insurance companies should be ashamed of themselves for, they should cover any procedure that would help alleviate that problem. All right, any questions?
Yes, we have a question from Bali on Facebook.
Uh-huh.
They asked, "Hello, Doc. Amazing job. Do you perform a lot of hip laser surgeries, and do you show them live on Facebook?"
Yeah, great question. So we do perform hip surgeries now. We have developed a new technology called Deuk plasma rhizotomy, where we go in and kill the pain from people's arthritic hips and knees, so they don't have to have open surgery. We started doing those this year, and it's working, but it's not laser. There's something wrong with the laser setting. It seems too fast, but maybe I'm wrong. All right, could be I'm just imagining it. After all, I was missing on the hammer. All right, now, so to answer your question, if you have hip pain, knee pain, arthritis in your hip and knee, don't get a knee replacement, don't get a hip replacement. Come to Deuk Spine, see one of our doctors, Dr. Patel or Dr. Davis, our orthopedic surgeon, and they can assess you for a much safer and simpler surgery where you could be up walking and going back to work the next day without narcotic painkillers. No narcotics, no narcotics, no narcotics. Very important. Why did we not need narcotics after our surgeries? Because we don't cause trauma to the patient's body during the surgery. The only reason patients need narcotics after surgery is because the surgeon hurts the patient. Do you guys not understand that? I mean, it took me a long time to think about this and figure it out. When you go get a shot, do you take narcotics afterwards? No, because the doctor did not harm your body internally. The reason you get pain meds like narcotics after surgery is because the surgeon is hurting you. Well, with the Deuk laser disc repair, we don't need to hurt people anymore. We can fix people without using narcotics for the actual post-surgical pain. And then we do that with the Deuk laser disc repair as well as the Deuk plasma rhizotomy. All right, so the whole source of her pain, quite simply put, is this little area right here in the back of the disc where she has inflammation from the herniation. Any other questions?
No current questions.
All right, let's show the video showing how the Deuk laser disc repair actually works. What is it I'm doing with this laser? Why is it working for people that have discogenic pain? All right, well, I'll apologize for any spotty internet. We're still trying to figure out what the issue is and trying to get a hold of our network administrator to help us. All right, any questions from the audience?
No current questions.
There is something there, Luis, right there. Hold on. You see it? There it is. Hold it. There it is.
I find 2005 one,
No.
70,000. It's
70,000.
17,000.
I mean, what about our guy?
He's looking for it, and he sent a couple messages. I asked him yesterday. He's just waiting on their response. So. He
Oh.
actually, they are. He's talked to his boss. We probably can buy the one that they rent.
Don't buy it.
Right away.
Buy it.
Yeah.
Buy it.
So for sure we can ask for some warranty.
Yep.
I mean they can
Yeah.
fix it.
Ask him if they could
Yeah,
just
yeah.
service it. At least labor, you
Yeah,
know,
yeah,
even if I have to pay for parts. You understand?
I understand.
Yeah. All right, that's it. I can't get any more out.
So
I want to start, yeah.
thank you. Thank you, Jordan. You okay?
Oh, I'm fine, yeah. I'm just thinking about problems that I'm trying to solve. Yeah. All right, how are we doing over there, Henry?
Ron is on a call right now. We're trying to get a hold of him, but we're also trying to contact Jose simultaneously. And just
Did
trying
you
to
say Ron is here?
Yeah, Ron is here, but we're trying to get a hold of him. And so if
Send somebody over there to his office.
Sanjay's on his way right now.
Okay, thanks. Jose was supposed to be here today. Yeah. Shot? Take it out. My aim was better that time. How is she doing? Very well. Yeah, everything's going well here. I wish I could have seen the discogram, but we couldn't because we didn't have iodine contrast. Because she's allergic to iodine. So we've taken the iodine out of everything we're using today. All right. Any questions?
Yes, we have another question from Bali, once more on Facebook. And they ask, you mentioned you kill the pain from the hip or knee. Yeah, you mentioned you kill the pain from the hip or knee pain, but what about if there are hip movement restrictions, impingement, bone rubbing tears? Does that also get resolved?
Yeah, so great question. What's limiting the movement of the hip is the pain. When you eliminate the pain, the movement can come back. So yes, the procedure we do improves the function of the hip and knee because the pain is gone. And once pain is gone with movement, then movement can be restored, but you still have to build up your muscles. Yeah, because the muscles always atrophy with chronic knee pain and chronic hip pain, chronic shoulder pain. Any kind of chronic joint pain, the patient will guard the joint for years and not use it properly, and then their movement and the supporting muscles and tissues will atrophy and basically shrink up. So that takes time to build back up. But to restore normal movement, you need to start with eliminating pain in the joint. Yeah. The orthopedic surgeons will lie to you and tell you you need a new joint made out of metal. That's because they make a lot of money putting those joints in. Take away their financial incentive and they won't offer you any joint surgery. I guarantee it. They won't offer you any replacements. Okay? So the problem is what's driving artificial hips, artificial knees, artificial spine joints is reimbursement and big business, money for the hospitals, money for the surgeon, money for the implant company that makes those metal joints. They'll tell you whatever you'll listen to in order to get you to get that joint put in. So don't believe them. I used to be a fusion surgeon many years ago. So all I did was spinal fusions, thousands of them. And then I learned the truth. And the implant companies won't tell you the truth. If they tell you the truth, they'll go out of business. They don't want to go out of business. They make money on people getting metal put in their knees and hips. So as long as surgeons are putting metal in patients' hips and knees, they're making money. Okay? We're not putting any metal in people's hips and knees. We have a new technology that doesn't do that. And it's done naturally to eliminate knee and hip pain and restore movement. We're in the process now of going to be writing up our results soon and submitting them for publication. But everybody we've done this procedure on, it's worked. It's not a guessing game, it works. You gotta have Nikki doing something other than just running the laser at some point. I would give her additional responsibilities.
No, she has been helping me actually cleaning a washer.
Yeah, yeah.
Also wrapping, she's amazing.
Good.
And next week, our goal is to start jumping in a little bit by little.
Yeah, perfect, thank you. So you're progressing her through responsibilities. Yeah. So I contacted 2 more autoclave companies, just so you know. Who?
He texted me yesterday. He said, hey, any opinions? I didn't respond.
No, you don't need to respond.
Yeah, okay.
But I've got more quotes coming in, and I told him, I gave him fair warning. I said, give me a price that I can't go shopping anywhere else. And he didn't do that. So I have to shop. Oh man, look at that herniation. Show this. Turn on the light. Can you see this that just came out? Henry, Sanjay, whoever's there.
Yes, sir.
Look at the size of this herniation that just came out. You guys see it?
Yes, we do. Yes.
All right. Good. We've been pulling out smaller ones. That was just a big one. We call that the whale. Right? Actually, that's a small whale. We've had bigger whales that we've taken out. Anyway, it's a fun surgery for us because, number one, the patients do so well with this Deuk laser disc repair, typically, and the patients doing well, that's why we're here, okay? We're here for them. And we're not doing any bleeding or excessive pain. This is a mild, very mild surgery for them. They're able to tolerate it well, recover quick. Our patients are generally back doing normal activities the next day, same day or next day. So it's wonderful. All right, this is the 4-5 disc. Next, we're going to get down to the L3-S1 disc. Any questions? This is the herniation you're seeing, by the way, right here. All this blue thing. It's stuck to the annulus right there. And the only way to unstick it is with the laser. There is no other way. I get people saying, why do you need the laser? Why do you need the laser? This is why. You cannot release the herniation from the annulus without the laser. It's impossible.
We have a question.
Sure.
This comes from Premier Media Group on YouTube.
All right.
They ask, good morning team, how can scoliosis progress concurrent with disc/vertebral body injuries?
Yeah. So scoliosis, the question is, how does scoliosis progress concurrently with disc or vertebral body injuries? The spine is called the spinal column. It's made up of structures that support the weight of your body. As a matter of fact, the entire weight of your body is supported by your spine until you get to the pelvis where everything is supported by your legs. Okay? So all that head and neck and shoulders and all your organs inside your thoracic cage and a lot of your abdominal organs, they all attach to your spine. So your spine has a lot of weight attached to it. And because of that weight, it's constantly being compressed downwards. Now, normally you have a curve in your spine called, it's in what we call the sagittal plane, and it depends on the body part, like thoracic versus lumbar versus cervical. But you have a lordotic curve in the cervical and the lumbar spine. You have a kyphotic curve in the thoracic. Okay? Those are normal curves. Anything other than those is abnormal. Now, if you start twisting in a different plane, like the coronal plane, you're going to get a deformity we call scoliosis. All right? And scoliosis is not normal, but at the same time, it's not the cause of symptoms. Okay? It doesn't cause symptoms unless it's severe. And a lot of times, the only people that really need scoliosis treated are young children in their teenage years. They have juvenile idiopathic scoliosis. But what I found is the vast majority of scoliosis is adult onset, and it's called degenerative scoliosis. Now, what causes this, I believe, is basically injuries to the discs and facets, not the vertebral bodies. It's not common for vertebral body injuries. So if you injure your discs and you injure your facets, or both, which is most of the time both, then what's going to happen is your spine is going to collapse. It's like having a puncture in your tire. The spine will start to settle. Now, as the spine settles, you'd hope it settles straight down, but it doesn't. It settles asymmetrically, with one side settling more than the other. And we call that a deformity. When it starts creating a curvature that's pronounced, we call it scoliosis, when the curvature is in the coronal plane. Okay? Coronal deformity. I know it's complicated, but basically the most important thing to remember, if you have adult onset scoliosis, 99% of the time you don't need to fix it. You just need this exact surgery you're watching. Far less invasive, much safer than scoliosis surgery. I found that the scoliosis surgery is completely unnecessary in adults. Okay? Juvenile scoliosis, different story. Adult onset scoliosis, completely unnecessary 99% of the time. All people need done is they need their disc fixed. Now, what's really happening out there is the surgeons are telling patients they have to have scoliosis surgery. Okay? And why? Why are they doing that? It's all being driven by the implant companies. The companies that manufacture screws and rods. That's what they're treating the scoliosis with. Fusion. Fusion requires the use of screws, rods, and implants. Whether it's biological implants, like bone graft, or osteoinductive or conductive or genesis type implants, they're called biological implants, or screws and rods and cages, okay? The point is those companies are making billions of dollars a year profits on putting those implants into you, the patients. And they're using scoliosis as the excuse to do it. All right, when you actually don't need it. This patient has scoliosis. We're going to fix her problem without doing scoliosis surgery. The scoliosis surgery is totally unnecessary. We do this all the time. We fixed thousands of people that have scoliosis without doing scoliosis fusion surgery. So think about that. All we're doing is fixing the disc or the facets. I don't know if that answers your question or not.
Jordan.
What do you need? More Ratex?
Yeah, but
All right, we're pretty much done with this here disc. We've gotten everything I can get out. I don't see anything more. What's left is the actual normal disc. What's left is not normal, but it's the normal disc. It's what she normally has. The disc is not normal. It will never be normal. And that's something that I have to tell patients sometimes is don't expect your MRI to look normal after surgery. It will never look normal. Once you've damaged your spine, it's always going to look damaged. It's not going to change much. These surgeries we do don't make your spine look normal. They're not cosmetic surgeries. All right. Any questions from our audience?
Yes, our next question comes from Dale on Facebook. And Dale asked, with lower back pain, is it normal to get pain in the pubic area?
All right, with lower back pain, is it normal to get pain in your pubic area? The answer is no, it's not normal. However, there is one thing that can cause pain in the pubic area from your back, and that is your sacroiliac joint, your SI joint. All right, if you have sacroiliac joint inflammation and pain, it can shoot forward to your pubic area. That doesn't mean your pubic pain is coming from your SI joint. It just means it can happen. I've seen it happen. It's not common, but it's not terribly uncommon either. There are other causes of pubic area pain. It's definitely not a herniated disc at like L4-5, L5-S1. I get that question a lot. That's 100% not the cause. Shot? Okay. So I would talk to your doctor, have them assess your pubic area, make sure you don't have, if it's a guy, you want to make sure you don't have a hernia or a epididymitis, which is inflammation of your epididymis, or I don't know, what are some other things? What's it called? The seal? Huh? Cystocele? No, not a cystocele. It's spermatocele, varicocele. Yeah, there are. Wait, let's see here. Hold on. Let's get that out. There are lots of causes of pelvic pain, shot, that have really nothing to do with your spine. And yeah, it's a little too much. That's better. It's got a short disc. Very short disc. That should be good. All right. So there's a lot of causes of pelvic pain that have nothing to do with your spine. I would say the chance at your spine would be just 1%. There's a 99% chance it's something else in your inguinal canal or your pelvic area. All right. 10 minutes, Dr. Berndes? Yep. All stable? Good. Yeah. Wonderful. She on the CPAP? Oh, yes. Nice. Working good, huh? So. Yep.
So we ordered a new device got two of them, right? It's a padded horseshoe. So instead of the black horseshoes that we routinely use,
Uh-huh.
it's made out of more of a foam padding.
Uh-huh.
And it has a
Laser.
area in it where you can put the CPAP tubing through it.
That's
So it
wonderful.
fits perfectly.
And it's more comfortable for the neck.
Found it out for us. They use it in the ICU.
See?
And I have never seen that device.
Collaboration. I love
I
it.
never saw that device in the ICU. So that was cool.
That's because you were not in the ICU very much.
Well,
Thank God.
I spent a lot of time.
No, I know. I'm joking.
Just didn't,
You had to rotate through the ICU, I'm sure. Did you ever get called for emergency innovations?
no, but I did some ICU stuff with cardiac surgery and with transplant.
I never enjoyed the ICU. Never. Never. My least favorite place as a neurosurgeon was the ICU. All right, we got 5 minutes left. We're almost done with this patient's surgery. Hold the tube. Hold the tube in place. We're just finishing up the last disc, L3-S1. And this one is the smallest of all. Hold the tube. Yeah. This one is the smallest herniation. It's more of a disc bulge. Come on. You can actually see the blue stuff there is the herniation. And we're right on the outside of that disc. A little bit of fat. Shit. Getting in the way. Call that epidural fat. This was a hard one for me to get into because of her facet was pushing me south where I didn't want to go. But we eventually got in. This is all scar tissue right there from the herniation. See that in the golden color, the orange color? That's calcium. This is a very nice scope, by the way. Like the optics are beautiful. Very nice. Are you guys keeping a log of the scopes? So this one I would call light use. Though I did blast the laser right near the lens. Yeah, I did. Yeah, so maybe you should put, maybe you're right. Maybe we should put heavy use. Well, I made a boo-boo. You know, I had the laser up here. When I blasted the laser, it was in the housing for the scope. So you could just, you know, disturb the lenses and shake them up a little bit. Luis knows. That's my fault. I have myself to blame. Can't blame anyone else. And I have no problem taking blame when it's my fault. That's how I've become successful at what I do, is by being willing to accept fault. You know, a lot of people try to push blame off. Like, take my wife, for example. She never admits to anything wrong. Never. Never. But at the moment I do something like slightly wrong, she's on me like a pit bull at my jugular. Right? The other day I called her because I did something stupid and I knew she was going to find out eventually. So I just called her and I said, listen, I want you to know that I did this stupid thing. And you're going to hear about it at some point, but I want you to know I take full responsibility. So, and she was actually a little gentler on me because I did that. I was surprised. I did call her though. That's the key. Because I figured if she started giving me a really hard time, I could just click off the phone. Oh, you know what? I'm in a bad area. I'm so sorry. Really bad reception here. I'll see you later. Checking into the hotel this afternoon. All right. Are you guys tired of my jokes yet? Where are the questions? No questions? Are we still streaming?
Yes, we are still streaming. This next question comes from Bali, once more on Facebook.
Dolly or Bali?
Bali. B-A-L-L-I-E.
All right, Dolly.
And they asked, for this patient you're doing now, you will be repairing all their 3 discs via the same incision?
Yes, that's right, Dolly. 3 discs, 1 incision. And I tell you a little bit in the beginning, if you watch my technique, I know I make it look easy, but the reality is not easy. L3-S1 is a transforaminal disc repair, endoscopic, very hard to do. That's why I start with L3-S1, because once you get the L3-S1, the rest of them are easier to get, L4-5, L3-4. So I always start with the hardest one, and that determines my entry point. And then I basically say, okay, if I can get the other discs fixed, you know, through the through the incision that I make for L3-S1, great. If I can't, then at least I tried. But I'm not going to compromise the quality of my surgery just so I can have 1 7mm incision. In other words, if I have to, I will do another incision. You guys could see the tear right there. You see it, the blue tear? It's like if you're mining for gold, you'll find a vein of gold. That's a vein of tear and herniation. That's what we're looking for. Every one of these patients with pain in their back from a disc has a tear. And that tear has a herniation in it. It's like a vein of gold. But it's not gold. It's just a herniated disc. You guys see it down there?
Yes, we do.
That's what I'm here to fix. There's a little bit of bone. A little bone spur. Can't even get it through. So yes, we can remove bone spurs with this endoscopic surgery as well. A lot of people ask me, can you remove bone spurs? The answer is yes, we can. But you see the normal disc right there, the white stuff? And then you have the herniation, the blue. So it's kind of a nice image. You could see the herniation is really not the whole disc, it's just part. People ask me, are you taking the whole disc out? The answer is no. I'm only removing the herniation. That's why we use the blue dye. The blue dye helps me to see good from bad, what I should leave versus what I should remove. Okay? Now, we're never going to get 100% of the herniation. People ask me about that too. Oh, I got an MRI. I still have some herniation. That's right. We're not taking all your herniation. There's no way to get 100% of herniations out. If we get 50%, then symptoms go away. Okay? All right, I got 1 minute left. Just about done.
We have another question.
Uh-huh.
This comes from Premier Media Group on YouTube.
Yep.
And they asked, last question today for me. Since discs take over a year to heal, less than a year to heal, greater than a year to heal, what are the risks for re-injury to annulus during the healing period?
Yeah.
What consideration should patients have for resumption of activity?
Yeah, great question. We go over those questions with our patients when they come here for surgery. But to answer your question, it's very simple. Number 1, no lifting over 25 pounds for the first 6 weeks. Number 2, no lifting over 40 pounds for the first year. After 1 year, your disc is healed. You can do whatever you want. And you can go motocross, you can do jiu-jitsu, you can do skydiving, it doesn't matter. At the end of the year, scope off, your disc is completely healed, and you can do whatever you want.
Sitting on, please. Thank you.
And yes, it does take a year for the disc to completely heal. Why? Because the disc does not have a good blood supply. It has a poor blood supply. It's one of the worst blood supplies in your whole body. Therefore, it heals slowly. You need blood supply to heal. Your tissues that have the most blood supply heal the fastest. Your muscles, your heart, heart doesn't really heal once you damage the heart muscle. But generally, the tissues with more blood supply, the faster they heal. And the reason is that healing requires your inflammatory system, which is why your disc has problems, because you have too much inflammation in the outer part of the disc, which is the only place the disc has a blood supply, the outer part. So for the disc to completely heal from out to in, show the audience the incision. You guys see it?
Yes, we do.
Three discs causing 9 out of 10 pain, 8 out of 10 pain, 10 out of 10 pain, gone, fixed with a 7mm incision. Great job, everyone. Great job. I'm going to call the blood loss 0.5 milliliter. 0.5 milliliter. No complication. All right, we're all done. If there's questions, I'll be happy to answer them. Otherwise, we can run a testimonial and end the broadcast. We have one more surgery today. Good morning, I'm Dr. Deuk Majan. I'm here with one of my patients and friends who I've known for years, and she has been suffering with back pain for, well, I'll let her tell you how long. And a week ago, she came and had the Deuk laser disc repair. She's here for a checkup, and I'll let her tell you how she's doing as well. So how long have you had your back pain for?
Started back in May last year, and I just couldn't get any relief from anyone. Finally, I asked you, and the rest is history. So this last week has been the best week of my life since May of 2022. So pain-free.
Excellent. Yeah. Now, I know it got bad last year, but did you have back pain on and off before that?
I did. I actually got thrown from a horse back in 2018 in Ireland. And that's what I think probably started it. I was having lower back pain, but never really did anything about it, just sort of lived with it.
Kind of modified your life, took it easy, try to avoid things that aggravated the pain.
Exactly.
And now I know that you were suffering so badly before the surgery, and here you are with a smile on your face.
Oh yeah, definitely.
Well, I'm so happy you're out of pain. You had the Deuk laser disc repair. You could actually see we use a laser to clean